Good evening and happy belated New Year to everyone. I'm Allison Elsner. I'm the Executive Director of the San Bernardino County Medical Society. And on behalf of SBCMS, in partnership with Riverside County Medical Association, or RCMA, we'd like to welcome you to tonight's panel presentation and discussion, COVID Treatment 2021, Outpatient Successes, Alternatives, and Options. We want to thank Dr. Eric Hansen for conceiving of this presentation based on his own experiences and interest in sharing ways to explore treatment options in the outpatient setting. Before I introduce our presenters tonight, I wanted to let you know that we would appreciate it if you would submit your questions, if you have any, for the presenters in the chat feature on your Zoom screen. Once the presentation session has concluded, Dr. Hansen will be facilitating the question and answer session. So first, I'd like to go ahead and introduce Dr. Hansen. I can get my glasses here. Dr. Eric Hansen is a DO, FAAFP. So apparently I've been muted.
Yeah, something happened.
Yeah. Have I been muted the whole time?
Well, I think you left off at, I think you were starting the introductions of the presenter.
Yeah. I didn't touch my screen, so it's not my fault.
Didn't happen. You can't run across the keyboard.
Okay, let's try this again. Eric Hansen, DO, FAAFP, is family practice in Hesperia, California. Dr. Hansen established his own family practice in 2002, is a board certified ABFM primary care physician and graduated from the Western University of Health Sciences, College of Osteopathic Medicine of the Pacific in 1999. He currently serves as the trustee for the CMA Solo and Small Group Practice Forum. He serves as a frequent presenter on how to establish a successful telehealth practice and is a member of the California Medical Association's COVID-19 Task Force and Healthcare Advisory Technical Advisory Committee. And he's also past president of San Bernardino County Medical Society. So welcome, Dr. Hansen.
Thank you.
Ashwini Mallad, MD, Infectious Disease and Internal Medicine in Apple Valley, California. Dr. Mallad is an infectious disease specialist working with Choice Medical Group, known for her integrity and empathy for her patients. Her special areas of interest include antimicrobial stewardship, bone and joint infections, treatment of multi-drug resistant organisms, general infectious disease care, and human immunodeficiency virus, HIV. She graduated from medical school at Vijay Anagar Institute of Medical Sciences in India and completed her residency in internal medicine at the Joan C. Edwards School of Medicine's Marshall University. She also completed a fellowship in infectious disease at University of Massachusetts School of Medicine. Welcome, Dr. Mallad. Roger Seheult, MD, pulmonologist, Beaver Medical Group, Banning, California. Dr. Seheult is Associate Clinical Professor at UC Riverside School of Medicine and at School of Medicine and Allied Health at Loma Linda University School of Medicine. In addition to being a preceptor for PA and medical students, he was the medical director for the Physician Assistant Sciences program at Loma Linda University School of Medicine, for a sleep lab in the area, and for the Crafton Hills College Respiratory Care program. He currently practices with Beaver Medical Group in Banning, California, where he's a pulmonologist and sleep physician. He is certified in internal medicine, pulmonary diseases, critical care medicine, and sleep medicine through the American Board of Internal Medicine. So with that, welcome to you as well, Dr. Seheult. So with that, I'm going to go ahead and turn this over to Dr. Hansen.
Thank you, Allison, and thank you to the entire San Bernardino County Medical Society staff. I really appreciate you guys putting this together, and we kind of did things on a really short schedule. It was apparent that this discussion needed to happen, and it probably, in retrospect, should have happened even months ago, but better late than never. And the intention really is to try and share information with other physicians. So this conference is, or this discussion is primarily geared towards the physician audience, but I know we have a fair amount of lay public that will be attending tonight as well. So we'll try to keep things as straightforward as possible and not use too much technical jargon, but if you do hear that, know that it's for the physician's benefit to hopefully help any of the patients out there. The impetus for this discussion was really because of the fact that it became very apparent that physicians across California are really not on the same page in how we should address early COVID-19 or SARS-CoV-2, which is the virus in question that causes COVID-19 infections. So we have seen a huge disparity in the treatment of individuals, from basically being told when they go to maybe an urgent care or their primary physician that there's nothing that can be done, that if you get bad, go to the hospital, to other physicians that may be giving a full gambit of medications and supplements and other therapies. So it was definitely very important to try to get us all on the same page and have physicians and patients alike sharing of information so that we can hopefully mitigate this hospital crisis that we've been faced with for the past several weeks. Even though we've hit a bit of a plateau just this last week for the first time in several weeks, still we are nowhere near out of the woods, and with a potential mutated virus to deal with that may be more transmissible, we may be seeing huge spikes again coming up in the near future. So I really wanted to thank the other presenters, though, on this conference, Dr. Mallad and Dr. Seheult, because it's really important that the other physicians hear from experts in the field of internal medicine, infectious disease, pulmonology, and especially the work that Dr. Seheult has done. If you are familiar with Dr. Seheult's history, he's got almost 1 million followers on YouTube with his work since the onset of the pandemic. And so I really am proud to have him and Dr. Mallad on our call tonight. So starting off, because I know we got a lot of information to get through, I just wanted to give Dr. Mallad a chance, if she could, to just give us all a brief presentation on the pathophysiology of the SARS-CoV-2 virus, and in her opinion, why we see such a disparity in age groups affected, because we have heard a lot of things on the news, and we have a lot of experience in our own practices about seeing generally the more severe cases definitely in the 65 and over populations. And then we have a trickle down effect I know that I see in my practice, where we'll see fair amounts of patients, maybe 40 and over, but very few pediatric cases. In fact, the youngest case I've treated so far has been 21 years old with dermatologic manifestations of COVID. So with that, Dr. Mallad, if you could kind of let us have a little information from your insight in your history of infectious disease on this bad actor.
Thank you, Dr. Hansen. 1 second. Can you see my screen?
Yes.
So I'm going to be very brief about the pathophysiology. So basically, when the virus, we all know it has these spike proteins which attach to ACE2 receptors, and which causes internalization of the virus and goes through the process of replication of the virus. However, when this spike protein attaches to these receptors, they disrupt the ACE2 receptor results in inhibition of regulation of angiotensin II, which basically leads to damage of cells and tissues. And these angiotensin II receptors are very important for hypertension and inflammation control. When this pathway is disrupted, which causes more inflammation in the body. There is a newer evidence that there is autoantibodies, and this was just published like last week, that there's a role of autoantibodies that self-attacking our own cells, causing severe COVID-19 infection. Coming to your question about age group, like why there is different presentation. So in kids, they are not much affected. The possibility is that, you know, they are exposed to different COVID, like coronavirus. It's not this particular strain, but they seem to have a little bit immunity from that. But as you go older, you know, like especially with comorbidities, they tend to have very severe infections because of the decreased immunity in immunocompromised, like obesity, diabetes, which can affect the immune response.
Right. And if I could, just not to interrupt you there, but Dr. Seheult, as the pulmonologist on the call, the ACE receptors, are we seeing that is a significant difference in the number of ACE receptors in those pediatric populations in lung tissue specifically?
I'm not sure exactly if that's the reason. I think some of the evidence is coming down to show that it's actually the innate immune system. There's two parts to your immune system, the innate immune system and the adaptive. And as you get older, the innate immune system becomes weaker and weaker. And in children, the innate immune system is incredible. You know, a kid gets a virus and they've got a fever, they're off to the pediatrician. What seems to be the case is that the virus inhibits that innate immune system early on, and that's why you get a pre-hospital course like we've seen. I'm not sure if the ACE inhibitors has a lot to do with it, although there may be a connection there.
Okay. And Dr. Mallad, if I could also, along these lines, when we are testing patients with either PCR testing or when we do testing with rapid testing for antibody, we have a huge disparity in those findings, it seems. At least in clinical practice, for my practice, I would suspect that we have potentially even as high as a 40% false negative rate on PCR testing. And I wonder about your experience with that. I know primarily you may see patients that are more in the later phases in the hospital and such, but do you believe that there could be a potential link to viral load numbers and the positivity? And maybe Dr. Seheult has an opinion on this as well, but I ask your opinion on that.
I think like there could be multiple reasons why, you know, there could be false negative. One is, are they using the proper technique? You know, that's one of the concern.
Right,
and
cool.
When, at what point of time they are testing, you know, like sometimes the viral phase is like a week and it's gone. Like after that, if you're doing testing, you know, then you may not have results. But the other thing also, the test itself, right? There are, depending on what technique they are using, there could be discrepancies.
Right. And Dr. Seheult, do you have an opinion on that as well? Because I know
think Dr. Mallad said it perfectly well.
Yeah, because I know that just in my own personal experience, I had 2 staff members in my office that were symptomatic for a week, and we kept doing rapid tests on them. They weren't coming up positive. We had them do PCR testing. One came back positive, one came back negative. Not till 10 days did the PCR testing finally come back positive on both. And then not till 14 days did the rapid antibody testing become positive on both. And then I became symptomatic 4 days after initial contact with them and never had positive testing on any of the PCR or rapid antibody tests. So it tells us that as clinicians, we need to treat the symptoms because we surely cannot rely on the test results to treat a patient. And also we need to make sure that we're educating our patients that just because they go and they've got symptoms of shortness of breath, chest pain, they've got high fever, they've got headache, and they had a positive contact with someone, but they got a negative test. So, oh, I'm fine. My test was fine. It's negative, and that they don't just go out and start spreading this virus everywhere. So that's another thing. I just was curious about your opinions on that. So
just one quick, like we see currently in the hospital that, you know, some patients develop severe symptoms after the initial viremia is gone, okay? And they come to the hospital, they're requiring oxygen. And some of the hospital protocol is they need positive COVID test before we can give remdesivir.
Right.
And like, it may not be always true. We need to relook, like when we are testing, as you said, you know, they can be negative, but it doesn't mean it's not COVID.
Right.
So, yeah.
Dr. Seheult?
Yeah, exactly. I mean, there's false positives and there's false negatives. We've seen also where people have been no longer infectious, but they maintain a positive test for weeks, and you're just picking up
Yeah.
particles of the viral RNA and turning the test positive on the amplification. So
Right.
you gotta do it just like we're trained as physicians, as medical providers. We need to couple the clinical with the test.
Right. Well, thank you. I was really interested in your opinions on that because I absolutely go down the symptomatology when I get messages from patients, and definitely not relying on the test results for sure. That's nice. It's an added thing that, you know, they'll call me 4 days later because we advise them to get tested. And I would say about half of them will tell us, oh, I came back positive on that. But now I've got severe shortness of breath. And so that kind of leads us into the next thing. And I wanted to, maybe we can start off with you, Dr. Seheult, on this one, because the main impetus again on this webinar was to really help physicians understand not only, you know, why it's important to treat early, but also options on that early treatment. So if you could maybe give us an opinion from your perspective on why early treatment and identification is important, especially in the inflammatory cascade that Dr. Mallad was, you know, leading to with the ACE receptors, and what happens with after that, the inflammatory markers.
So I think the biggest thing to take home on this is that COVID really has two phases. I mean, it's a little more complicated, but to simplify it, there are two phases to this infection. There's the phase before the patient gets pneumonia, before they become hypoxic, and that's the phase where they're at home with fevers, chills, muscle aches, and things of that nature. And in that situation, that is a very different entity than what we see when the patient comes to see me in the intensive care unit or in the hospital when they have COVID-19, they have pneumonia, hypoxemia, they're on high flow. And the difference really has to do with the immune system. Early on, it's really the job of the innate immune system to take care and to knock down the virus, to present the viral particles to the adaptive immune system. And what we're seeing, just like SARS-1, just like MERS, is we're seeing suppression of the innate immune system, and that's causing the virus to infect and go into many, many different cells. Once they're in the cells, antibodies, antiviral medications really don't have much of a role. And that's why we're seeing like medications like remdesivir are not working later in the disease, because they have a role up front. That's why like monoclonal antibodies that we'll talk about, like bamlanivimab, has a much better role within the first 10 days of the infection, preferably even earlier on before the virus has gotten into a lot of the cells. And so we'll see this. There's a number of papers that were published in Science that show that people with genetic abnormalities that don't allow them to mount an interferon response, which is part of that innate immune system, almost always in the cohort have severe COVID disease. Antibodies against interferon, again, severe COVID-19 disease. So early on, the role, I believe, should be to enhance the innate immunity to do the job that it's really cut out to do. It's the job that young people have with their great innate immune systems. Later on, once they get into the hospital, now we can talk about steroids. Steroids work great. They work the best in the sickest patients. They don't work very well in those that are not on oxygen. And so one of the first things that we got to clear up right from the very beginning when we're talking about treatments is, what phase of the disease are we talking about? Is it pre-hospitalization or is it post-hospitalization? And so clearly we're talking tonight about pre-hospitalization. And so the type of things that I think we ought to be talking about are things that enhance the body's immune system to be able to take care of the virus.
Right, and that's exactly what we'll focus on. And you had touched on a few of the things as far as the symptoms that are, you know, important to note as well, because there's early phase symptoms, and like you had pointed out, you know, you can say some of these. I mean, because I know, and from my experience, it's nasal congestion would be some of the very first symptoms in phase 1, rhinorrhea, maybe some fever, headache, and then you'll progress to fatigue. Then you may have cough, anterior chest pressure, shortness of breath, myalgias, and then even in some of the younger patients, the dermatologic manifestations. I had some that had some mild respiratory symptoms, and then they seemed to resolve, and then all of a sudden they developed a geographic rash over their entire body. And I had to do, and we'll talk about medications here later, but what I did make a difference there. So we've got to be on the lookout as clinicians that there's multiple different manifestations of this virus, and it's not just always going to be a respiratory manifestation. And so along those lines, as far as the late phase, and I know Dr. Mallad and both Dr. Seheult have both experienced, you know, inpatient symptomatology. And so as far as those are concerned, I'll even just talk about that since we're not going to focus a lot on inpatient. The reason is that the hospitals are pretty good about sharing information and protocols with each other. And so the main thing was really to work on that whole early phase. But in that later phase, the shortness of breath progresses, higher fevers, respiratory failure, and even we're seeing more multi-system failure. And one thing I haven't, and Dr. Mallad, I think, has some slides on multi-system failure that we'll kind of conclude with. But one of the things that I haven't heard a lot of talk about, and I was interested in your opinions on this, is hypercoagulability. You'll have patients that'll be maybe only 40 years old and they don't get very much respiratory symptoms. They just feel run down, and then all of a sudden they have a stroke and they come up COVID positive. And I've seen this in at least a couple cases, and or a myocardial infarction. So do you guys have any experience with that or an opinion on the hypercoagulability from this inflammatory cascade? Maybe Dr. Mallad first, since we gave Dr. Seheult a chance last time. And if you don't, we can punt to him.
I think we should point to him.
Okay. So I just in the last week, I had a very unfortunate case of a lady who had bilateral thalamic strokes and brainstem infarct. I mean, basically, she went to being completely functional to being basically locked in comatose permanently because of a stroke. Very early on, I was very pro prophylactic full dose anticoagulation. And what did that end up with? We ended up with people with compartment syndromes in their arms with spontaneous bleeding. We had a patient with basically the abdominal rectus muscle hematomas that bled into their peritoneum. And these were people on full dose anticoagulation, some of them with PEs. Here's what the result of all of that data is that the Hematological Society has said, look, if you've got a patient with just COVID-19, and even if they have an elevated D-dimer level and they have no evidence of VTE whatsoever, prophylactic anticoagulation is the answer. No intermediate dose, no high dose. Unless these people have significant risk factors for thrombosis, we shouldn't be discharging them home on anticoagulation. And that goes against what I initially was doing. I mean, I've heard these stories, and you have too, about people being discharged from the hospital, recovering from their COVID-19, only to get a thromboembolism and either come in very sick or die.
Right.
And so the question is do we treat them prophylactically? And I think we want to do that. But what I have seen as a result of doing that is a bunch of bleeding.
Wow. And even low dose aspirin, would you have an opinion on 81 milligram aspirin even?
I think that's a reasonable thing to do. And I'll tell you why. It's because we are seeing people, the clots that we're seeing, there was recently a New England Journal of Medicine article that was published looking at autopsies. 9 times the amount of clots in the lungs in COVID autopsies than in regular non-COVID autopsies. And they were full of platelets, megakaryocytes and platelets. So I think aspirin probably has a role. There's another issue though with aspirin, and that is my concern is reducing the body's innate immune system with killing fever. And I think that's a big topic. It's controversial. We are trained from when we are baby doctors as medical doctors is you have a fever, you treat the fever. And I think it's actually the wrong thing to do.
Yeah, and that's actually a perfect lead in because that was the next topic. So Dr. Mallad, I'm going to go ahead and just let Dr. Seheult roll into this if that's okay with you. And then I'm going to hit you up with another question after that. But the topic about fever, you've actually done a full YouTube presentation, I think, on this. Did you not? And we can actually put some links up in the chat about how to get to your YouTube page, because that's very informative for physician and lay public alike. But just briefly on that, if you don't mind, just kind of getting into the temperature aspect.
Yeah, so this has been a debate that's been going on for a long time. And I want to be brief here because there's a lot of information. Basically, the innate immune system stimulates interferon, all of this through fever. That's how it tells the body that there is an infection. And it's sort of the last gasp of the innate immune system to try to get things going. And what do? We kill it with aspirin. We see a patient in the hospital with fever, and instead of trying to figure out why, we give Tylenol because we think by treating the fever, we're gonna get somewhere. You know, 100 years ago during the 1918 pandemic, this is exactly what they did. They had just gotten Bayer aspirin. It was invented in 1899. It was discovered, and they used it extensively in treating these people coming back from the First World War with the flu, the pandemic. And they treated them excessively with aspirin, thinking that it was the fever that was causing all of the deaths. This was in the army camps across town in a number of sanitariums at the time that were run. They had a completely different approach. They saw sunlight, fresh air, hydrotherapy. That's actually trying to get the heat, the body temperature up actually in adults, because we have a hard time doing that because of our innate immune system. They had a much lower mortality rate in those sanitariums compared to what was going on. It's not a randomized controlled trial. But if you look at the science data that's coming out now, very good science that's coming out that shows that elevation of body temperature improves the very areas of our immune system that's crippled early in coronavirus. If you take monocytes out of the human body at various different temperatures, once you get to about 39 degrees, which is about 102 degrees Fahrenheit, the amount of interferon response from monocytes is 10 times that amount at 38 degrees. And that's exactly what we're missing. So if I see a fever in somebody, I say, great, that's exactly what the innate immune system should be doing. If I don't see a fever, I wonder, and we can get into this later and talk about the data, but increasing core body temperature with baths, hot towels, hydrotherapy, that sort of thing, I think it's a very low risk, potentially high benefit thing that we can do for our patients.
Right, well, thank you. And I'm going to cover, we have questions coming in through the chat. I've got other things written down, so I'm trying to handle about 4 different things at once, but there's a couple things we should touch on. One is going to be, there was a question, are our recommendations going to be able to be posted? I have an outline that I've actually given to Allison and the staff at SBCMS that we can post after the talk. So if you're losing track of numbers and dosing and those kinds of things, that'll be on that outline. The other thing that someone had a question that's timely, because they were asking about use of Eliquis, and you were already talking about, moderate anticoagulation and if it should be used or not. So as far as an ultimate recommendation on anticoagulation, would you say that you would maybe reserve that for your vascular paths and maybe do more than low dose aspirin in an outpatient setting?
Yeah, so I just got asked this question today, fortunately, by someone else. So I looked it up, and the Hematological Society does not recommend outpatient post-discharged anticoagulation with Eliquis unless they say they're high risk. And the article goes on, and I can send you the article. It goes on to list what those risk factors are. I wasn't able to find them quickly enough, but unless there are risk factors, and I'll have to look and see what those are, they do not recommend outpatient anticoagulation with Eliquis.
Okay,
I have it if you want. So it's called improved score if it's more than 4. So basically it has previous history of VTE. It gives 3 points. Malignancy in last 6 months treatment, it gives 1 point. Thrombophilia, it gives 3 points. And age more than 60, it's like 1 point. So if anything more than 4 while the patient is in the hospital about to be discharged, or if basically they say if the patient is going where he will be immobile, basically bedridden. So those can be where you can think of, but they don't recommend for everybody. And this is based on non-COVID patient studies where they found it could be beneficial, but it's not a strong recommendation.
Oh, thank you, Dr. Mallad. And if you could, maybe you could send that link for that article to
Sure,
Alex.
I have in my slide. I can.
Oh, great.
Sure.
So that way we'll be able to share that later as well. And
Okay.
so to kind of keep the ball rolling here, because we've talked about, okay, why is it important to treat early? What are things that we can do now is the next phase of really where we should go. And I'll just talk about in my clinical practice what I do, and then I'll let the other presenters talk about their opinions on that and maybe what they would recommend from their perspectives. So the temperature thing was something I had not been necessarily focusing on. So that was really interesting when I watched Dr. Schmaltz's YouTube presentation on temp. So that's one thing right there, because we had been telling people only Tylenol in general with anything related to COVID. I think that was, potentially related to not wanting to increase cardiac events, with use of NSAIDs and such. The other thing that when I get a patient that's calling me with pretty specific symptoms, it's usually this anterior precordial chest pressure with some shortness of breath. They may have some headache. And that a lot of times is really, I would say, the majority of the initial presenting symptoms. And that's different than influenza. And that's the thing. People are trying to say, well, wait a minute, we've got now no flu, well, that's not necessarily the case, because you can actually distinguish the difference in some early phases of influenza. That'll initially start with a little bit of sore throat. You may get that headache. You're going to get the high fever and myalgia. So there is some crossover, but this anterior chest pressure and the shortness of breath thing, that's a little later in the phase on the influenza patients, it's seen. So you can kind of distinguish. The other thing is we've been wearing masks habitually for almost a year now. And so we're not transmitting the lesser transmissible diseases, I think, just as easily as we used to. So that may be why we're seeing less regular cold symptoms, and why COVID, which is pretty easily transmitted, is maybe being presented. The other part is that physicians probably are a little bit gun shy that everything that looks like COVID is COVID until proven otherwise. So there's a huge crossover, but the problem is if we don't act early, then we end up with patients that have started on this inflammatory cascade in the lungs, that the lung tissue is starting to be destroyed, and they are the ones that end up getting intubated and still not saved. So if we can do something to interfere with that process, that's what we need to be doing. So what I'm doing initially is actually a protocol where I'm advising on zinc daily. And it's not just the amount that you may get in your multivitamin, which might only be 5 milligrams or the like. It's actually 40 milligrams, but only in the patients that are symptomatic, and only for up to potentially 21 days. After that, I have them go back to maybe a multivitamin and go from there. And I know Dr. Seheult's got plenty of work he's done on this subject. And these numbers are all going to be in the information that we were talking about, so you don't have to write all this down. The other one, which again, Dr. Seheult has done a bunch of work on, and sorry to keep saying his name, Dr. Mallad, because you've got your expertise as well. It's just, this guy has really studied COVID. And so the other is vitamin D. And I had actually been advising on 10,000 international units, seeing that that may be a little bit heavy. I altered it to 5 to 10,000, with reserving the 10,000 for those patients that I know were already vitamin D deficient. And that, again, is only for that short term, potentially like 3 weeks. And this is what I'm doing. And this does not mean that this is what's proven. It doesn't mean that we've had double-blind studies. We do have some studies on some of the supplementation, but then I'll get into the next portion. And then the other is the potential for the use of a broad-spectrum antibiotic. And there's been a lot of talk about Zithromax or even doxycycline from other physicians in the infectious disease world. Because of the potential crossover effect that causes an anti-inflammatory effect on that antibiotic, and not necessarily that we're trying to give something that's antibiotic for something that's viral. And so the other issue is, and Dr. Seheult can talk about this after I finish, is the potential for secondary pneumonias, which I know initially we were thinking we were seeing more than we actually are, that we're probably seeing more pneumonitis and not necessarily pneumonia. So that early intervention with a broad spectrum antibiotic may or may not be necessary. Other than the fact that you have people that have that pneumonitis, that inflammation occurring, and they will feel better for even a short period of time if you give them like a Zithromax or doxycycline. So sometimes I do it, sometimes I don't. The other one, which has gotten a lot of attention, I know Dr. Mallad's got some slides on this, I believe, is Ivermectin. This is a medication that's been out for almost 20 years, I believe, an anti-parasitic, which I can let Dr. Mallad give us more information on. But this medicine is shown in vitro to have significant response of potentially lowering viral load by 5,000 times, has been some of the preliminary studies in vitro. Of course, this is not in studies on humans, but if we wait another year, then we can have that. In the meantime, we could potentially save some people by utilizing medications that we repurpose, that we know are not potentially significantly harmful. Anything we take into our body can be harmful, but as far as the risk to benefit ratio, much higher to potentially have benefit than the risk. So that's the other, and the dosing on that, I can put in the slides, but generally I'm doing, because it comes in a 3 milligram tablet, 4 tabs at 1 dose every other day times 5 days. And there's been variations on this. I know other infectious disease doctors are going to 7, even 10 days on it. And it may determine maybe by the illness of the patient, the acuity of that patient. The other one that's been significant that I've been doing is actually an inhaled corticosteroid. And Dr. Seheult, you can give us an opinion on this. We'll go down the line here in a moment. But I've used either Symbicort or even Advair. I'm not promoting any type of brand over another, but an inhaled corticosteroid has gone to the point where it's given immediate, or at least within 15 minutes, potentially relief from the symptomatology of the inflammation, the pressure, the shortness of breath in these patients in early phase. And even to the point where there was a physician in Texas who was touting Symbicort use potentially even like 8 months ago. and that it was looked at as a potential cure. And I know that there was a question in the questions about another of the, I think, Pulmicort as a potential cure, but there's really no proof that there's any cure. But for symptom relief, I think they definitely have their place, and I use it regularly. And it's the difference between the patients at urgent care or other physicians' offices being given Tylenol and albuterol. And they'll get albuterol, they feel nothing different, or maybe just a little bit if they get it nebulized, but it's not really doing anything to reduce that inflammation. And I'll be anxious to hear Dr. Seheult on this, and I'm almost done with my portion. The other part is hydroxychloroquine, the medication that's been used again for 20-something years for my rheumatoid arthritis patients, for psoriatic arthritis patients, multiple other ones with autoimmune disorders. Use it safely at 200 milligrams twice a day, day in, day out for years. And never did I have to concern myself with if I was going to use an antibiotic in conjunction with that in the past. But in light of a potential maybe 1% possibility of a prolongation of QR interval and maybe an arrhythmia as a result, I usually will space out hydroxychloroquine if necessary at the end after ivermectin use, Zithromax, Symbicort, zinc, vitamin D. And at that point, they're off the Zithromax after 5 days, and I can safely, hopefully, use hydroxychloroquine if needed. And in those cases, it's usually when the severity of the respiratory symptoms have progressed. And I'll say just one more thing on that, and I'm anxious to hear the two of you give me some opinions on what I'm doing. The other is that in the past, with the use of hydroxychloroquine, it's not a miracle drug by any means, but when we have patients that have their inflammatory cascade going so far that they're having marked shortness of breath, chest discomfort, severe fatigue, inflammatory symptoms of every kind you can imagine. I've had patients where they were to the point where they were almost actually incoherent. The ambulance had been called, they're 80-something years old. The ambulance did not take them, said that, sorry, you know, we can't really help you, the hospital's full. They left them. And I started the patient on hydroxychloroquine, and within 12 hours, the husband called crying at my office saying his wife was talking to him and she was up and alert. Now, I don't think that was a coincidence, and I've had multiple other cases, the same story. Within 12 to 24 hours, dramatic improvement in the patient. And it's not everything, but it's too much to be a coincidence. So I'm done with that. So maybe I can give Dr. Mallad a chance first, and then Dr. Seheult.
So on this, I would like to share slide and just to show what's the current data, and then Dr. Seheult, he can give his opinion on it.
Thank you. And sorry to be like so verbose there, but all the physicians in the audience, I'm sure you were able to follow me there. And this is all on the outline, so you can kind of see that.
I'm going to only discuss about medications Dr. Hansen mentioned, and I'll skip slides which are inpatient. Okay. So basically, the biggest study until now, which was done by WHO, it's called Solidarity Trial for Repurposed Medication, and they studied hydroxychloroquine, lopinavir, ritonavir, interferon, beta-1A, and remdesivir. Basically, this study involved like 405 hospitals in 30 countries around the world, and they involved patients who presented to the hospital. And basically, the result was that have little or no effect on for 28-day mortality, initiation of ventilation, or in hospital like duration. And then, so basically coming to hydroxychloroquine, it is an immunomodulatory effect. It has immunomodulatory effect on various cytokines, including interleukin-1 and interleukin-6 and in vitro activity against SARS-CoV-2. So this is the study specifically was done in outpatient in early COVID-19. It's a randomized controlled trial for hydroxychloroquine. The basically population, the study population was 491 subjects. They were within 4 days of symptom onset. And they were randomized to receive hydroxychloroquine or placebo. And the primary endpoint was change in overall symptom severity within 14 days. Basically, it says that they did not find any difference between hydroxychloroquine and placebo group. At 14 days, ongoing symptoms were comparable between the groups. Medication adverse effect occurred, which were higher in hydroxychloroquine group, and there was no difference in hospitalization. But however, there were some limitation for this study because it was enrolled through internet-based survey, and patients were heterogeneous. And so they did not test everybody who were entering in the study. So basically 58% of the sample were tested positive for SARS-CoV. In short, the summary was that hydroxychloroquine was not associated with change in symptom severity, but adverse effects were more than placebo group. And then there's another study looking at the safety of the medication, which increased risk of QT prolongation among patients were given together. Hydroxychloroquine, azithromycin saw increased risk of QT prolongation and those not receiving. So basically, IDSA and WHO recommends against its use. I'll skip this because this is inpatient. Okay. Monoclonal antibody, quickly, I know it's used in like high-risk patients. Basically, it has a singular activity against predetermined target. Currently available target is the spike protein. There are 2 different companies which are making bamlanivimab, and Regeneron has 2. So IDSA also recommends against the use of routine use, but in ambulatory settings, however, can be given in high-risk patients after informed decision making as benefit is uncertain. So NIH also doesn't support since there's not strong data. The concept of inhaled corticosteroid, probably how it came, and Dr. Schultz can add more to it. This is what I found while I was reading. So definitely dexamethasone is the only drug which has shown like great mortality benefit. And it is recommended in severe COVID infection with saturation, less than 94%. So what they saw or noticed, especially, there was low prevalence of COVID-19 infection with COPD patients. However, the mortality was high, but the prevalence was low. So that's why they were wondering, is it because of something they are using, or is it greater measure of, they are taking extra precautions to prevent COVID infection. So there are currently, as far as I know, there are 2 trials which are registered in clinicaltrials.gov. So coming to ivermectin, in vitro study shows that it inhibits the host important alpha beta 1 nuclear transport proteins, which are part of the key intracellular transport process that virus hijacks to enhance infection by suppressing the host antiviral response. It also interferes with attachment of the spike protein to human cell. So this is not a FDA approved medication for viral infection. However, in cell culture, they saw that it decreases replication of virus. However, to achieve that plasma concentration, the dose required is 100 times higher, which is approved for human use or concentration. So this is from the data which is published in peer and non-peer reviewed journals. So some studies show no benefit or worsening after ivermectin. However, on contrary, some studies are reported showing shorter time to resolution of disease manifestation attributed to COVID-19, greater reduction in inflammatory markers, shorter time to viral clearance. However, there are a lot of limitations we should keep in mind. Like most of the studies, sample size was small. The doses they used were not consistent, nor the schedule. They were mostly like open label studies. They also used concomitant other medications along with ivermectin, so we cannot come to a conclusive evidence. Then there were confounding assessments of the safety of medication, and also severity of COVID-19 was not well described, like when was it given. So basically overall outcome was not clearly defined. However, this is most recent, NIH recently updated from, initially it was against the use of ivermectin, okay? So on 14th, they updated that they do not recommend against or for to the use of ivermectin in COVID patients due to insufficient data. So, okay, one more thing I just want to add is convalescent plasma. Since last 2 weeks, a lot of data is coming and clarity is coming about the convalescent plasma use. So basically, with high titer plasma therapy can prevent severe COVID-19 infection in older patients, especially if given within 72 hours. And it was published on 6th January. So basically it was a double randomized controlled double-blinded study, which had 160 patients randomized in each, like 180 in each group. And mostly the patients were above 65 with risk factors.
Right.
So
so along those lines, though, so for these, for convalescent plasma and for monoclonal antibody, just as the physicians in our group know, that's dependent on IV infusion, which can either be done at the ER or at some other infusion center, which the ERs have been a non-starter because of how impacted they've been with patients. And it's been difficult to achieve, outpatient infusion, I know in my area. So those, though they may work, it's a difficult barrier there. And so I
totally get your point, Dr. Hansen. And one of my colleagues who works in Illinois, and he is working along with the hospital support, to set up convalescent plasma for the outpatient setting, like, infusion. So this looks hopeful, where we are seeing everything is not working. Maybe, like if we are able to check the titer level, like especially the antibody titer level, which we currently don't do in most of the hospital, something, positive.
Right. And the other thing, and I'll get to Dr. Seheult here in just a moment, and thank you, Dr. Mallad, for that presentation. And I think what's difficult is, and you kind of touched on this, is that the studies are flawed potentially as well. It's not, we're getting good sample sizes. We're getting it in variable phases. So it's really difficult to assess. And then also we're using the medications in conjunction with other medications. And Dr. Seheult's going to talk about that, I'm sure, here in a moment, especially between using zinc and vitamin D and then potentially an inhaled steroid. So it's really a tough situation. And so if you follow the studies, then you end up thinking, well, nothing works. So then you end up with 50-50. Maybe it does, maybe it doesn't. And I think what we may also see is that some people may respond and some people don't. So is that a reason not to use the medications or to maybe jog if they're not improving within 72 hours? So there's a lot of ways to handle this. And so I'll go ahead and just for the sake of time, we better go ahead and let Dr. Seheult address. And we've got a lot of questions about multiple other medications that are experimental. And I didn't even touch on like fluvoxamine, some of these other medications that are out there that, they're trying everything right now is what's happening. You're seeing medications that are being repurposed because there may be something in their mechanism of action that potentially could be hopeful. And with that, Dr. Seheult.
Yeah, that's exactly right. So we got to remember back what we learned in biostats, that you've got observational studies, case control studies. These are retrospective reviews. At best, they are hypothesis generating. But really what we need to have are good, large, multi-centered, randomized, double-blinded controlled trials. That's what tells us if something actually works. Of course, it's a reasonable question to ask, do we have to know for sure something works before we give it in COVID-19 since we're in a pandemic? And that's a perfectly reasonable thing. And that's when we look at risk-benefit ratios. So I don't necessarily think we have to know for sure something works before we offer it in patients because there's a pandemic. But if we're going to offer it, we have to make sure that there's relatively low risk to that. So let's go through some of those ones that you'd mentioned. Zinc, we've got really good evidence on zinc in other diseases that it actually is beneficial in other viruses, like the cold virus, like things of that nature. Some pretty good data that you might be surprised if you went looking for. What I would be careful with zinc is, I take zinc myself, but just make sure you're not taking more than 40 milligrams of elemental zinc a day. Otherwise, your copper levels could go down. All right, so that's zinc. Vitamin D, boy, we've got great evidence. People don't know about the evidence, but it's pretty recent. Even before COVID-19, there was a meta-analysis that was published in the British Medical Journal that showed that supplementation daily or weekly with vitamin D cut down significantly on acute chest infections. And I consider COVID acute chest infection. This was before COVID, but it was pretty clear. It was a meta-analysis looking at 25 or so different randomized controlled trials. And that was the result that they came to. And that was before we saw in our studies here in the United States and around the world, the association, very strong association between COVID-19 diagnosis, SARS-CoV-2 positivity, prognosis with vitamin D deficiency. Now, we all know that association does not necessarily mean causation. And so, again, randomized controlled trials need to be done, but realize that the fat-soluble vitamin D, is probably one of the least toxic and least likely to lead to toxicity when you take it on a regular basis. Look, ever wonder why we seem to get flares of COVID-19, the flu, the cold in the wintertime when the sun is low in the sky? I mean, it doesn't take a rocket scientist to see this. In fact, they've done studies that show that latitude is correlated with not only SARS-CoV-2 positivity, but also mortality as well. And so those studies are being done. There's a shade study out of India that showed that 60,000 international units of vitamin D on a daily basis for 7 days in admitted patients with COVID-19 not only reduced inflammatory markers in those patients, but also increased the proportion of those after 3 weeks that had cleared the virus. There was a study in Spain that showed that calcifediol, which is the metabolized form of vitamin D, the 25-hydroxy vitamin D, the type of vitamin D that we measure in the blood, when that was given to patients coming in and randomized to that in the hospital, admitted, the ICU admission rate went from 50%, 50, to 2%. That was an astounding drop there with prospective supplementation of vitamin D. So here's what I'm doing. I'm actually measuring levels if I can, if they'll pay for it. I have sometimes difficulty with that, but I'm taking personally 5,000 units a day. This is for somebody who does not have COVID-19 to protect themselves. I would like to get the levels up above 50. Why? Because in a study that was published, 190,000 people published study showed that as vitamin D levels dipped below 50 nanograms per milliliter, that's when SARS-CoV-2 infection rates started to go up, regardless of age, regardless of race, regardless of gender, regardless of geographical location in the United States. So that's my target for that. And for me, that was 5,000 units. The Endocrinological Society says that if you want to take supplemental vitamin D on your own without doctor supervision, that the maximum for vitamin D deficient people is 4,000 international units a day. But if you as a doctor want to give more than that, so long as you're monitoring these patients, watching them and seeing, you can go up as high as you think you need to go. But I think that in terms of the supplements out there, the data that we have the most for is vitamin D. In terms of antibiotics, a couple of things to keep in mind. Out of the flu, the cold, any of these, I really am not seeing a lot of secondary infections with COVID-19. Yes, there may be a few, but it's much, much less than I see with the flu. And so I would really reserve antibiotics, especially in this era of antibiotic resistance, to those where it's a lobar infection, there's a patient coughing up purulent sputum, that sort of thing. And the reason why I say that is people might say, what's the risk? Antibiotic resistance, what? But there actually may be a detriment in that patient. I'll tell you why. We have some associated data that just came out recently this week that shows that the gut biome, so we're talking about gut bacteria, there are certain types of gut bacteria that have been shown to modulate the immune response. And what they are finding now is that in COVID-19 patients, regardless if they're on antibiotics or not, those patients that have a worse prognosis, those patients that have a worse progression, have fewer of those gut biome species in their gut. And so, is it possible that taking Rocephin, azithromycin, Zosyn, all of these things could change the gut biome and make a difference? We don't have evidence of that right now, but it's certainly a possibility, and there is definitely an association. In terms of inhaled corticosteroids, if somebody is going to be admitted to the hospital with COVID-19, they're going to be placed on dexamethasone. That's a parenteral, very strong steroid. By the way, someone asked the question whether or not you could use Solumedrol. Yes, in fact, the JAMA network did a meta-analysis on this, and they looked at studies that use Solumedrol. So yeah, so long as the dose equivalence is there, it's fine. This is like, using a handgun in a nuclear war. So if you're using mega doses of dexamethasone or a significant dose, that's going to go everywhere in the body, as it should, because you want to reduce inflammation. I'm not sure whether or not inhaled budesonide or Pulmicort in the hospitals could be benefit. Now, if you want to use it as an outpatient, I think that's certainly possible. But then again, I would caution that if the problem is a decreased or depressed innate immune system, then maybe we might have to be careful. What I want to see is a randomized controlled trial. Getting on to ivermectin. So again, what we want is a randomized, double-blinded, placebo-controlled trial that's peer-reviewed and published, and it's large and multi-centered. I haven't seen a single study in the ivermectin column that does that. There's a lot of close ones. There's some randomized controlled trials in other countries that have not been peer-reviewed or published. And I'm not to say that it has to be in the United States to say that we're so much better at doing studies. But the reason why I say that is because if you are going to use this medication on a population in Egypt, or a population in Brazil, or a population in Peru, that's a very different population than in the United States. And so I think for those countries, if they want to use it and they show an improvement in mortality, that's great. Here's the issue that I have. In almost all of these patients in the hospital, again, we're using dexamethasone. It's the only medication that has been shown to improve survival to date. And so if you look at the statistics on these patients in other countries, for instance, if we look at Brazil, I looked this up just the other day, the amount of subclinical parasitic infections, when you just do a random sampling, can range anywhere between 30 and 60% in these patients. So yeah, you hit them with steroids because they have COVID-19. Some of those patients may have had those parasitic infections in check, and now you're releasing it. And if you don't give a good anti-parasitic medication, you may have elevated mortality rates. And so now you throw in ivermectin, which essentially takes care of the parasitic infection. Are we seeing that kind of I don't know if that's the signal that we're seeing in these patients that may have higher than usual parasitic infections. And I'm not going off of what I think it might be. These are actual studies and data where they looked at rural Brazil, and they studied, and they see how many of these patients have ongoing subclinical parasitic infections. And the number in some of these cases was over 50%. So what I would like to see, and the good news is they're going to do this study. It's actually being done at Temple University in Pennsylvania, is a randomized controlled trial here in the United States, again, to look at this. And again, I don't necessarily say that we have to have this data to be able to use it, but we need this data to be able to say if it works. And so what's the risk of giving ivermectin? There's drug interactions and things of that nature. But what I would say is this, is ivermectin is a prescription medication. And so the group, I think the people that presented this out of Eastern Virginia Medical School and Paul Merrick, these are great guys. These are not wackos in any sense of the word. These guys are very studious. They've published a lot. What they are doing is exactly what I would do. You need to go to the NIH. You need to get buy-in from the people that can get the ramp up that you need to increase the production of ivermectin if in fact it works. Because right now, if you were to go out and try to get ivermectin at your local pharmacy, you cannot do that. Try to do that. You can't do it, especially if you say it's for COVID-19. That's another issue. But the problem is that finding these medications that work, that are already purposed, that don't have ramp up, you need to have buy-in from the federal level to get companies to increase the production of these things before you can say this is what works and this is what we need to use. Because as soon as you do that, you're not going to be able to have access to those medications.
Right. I'm already seeing that in our area for sure. And I anticipate that's a challenge. But like you had pointed out, that was being discussed through testimony at the Senate, just even I think last month or the month before. And so I'm hoping something gets done through that, but it will take further action for sure. But thank you for your points on that, because as you point out, I mean, we definitely have to treat the symptoms, and we may not know the complete picture at this point. And the thing that's going to get clouded is the fact that we're having so many medications. I mean, just like I had said, I think there was 3 new medications that were suggested to have positive effects on COVID treatment just since we sent out the invite for this thing. And so, you know, one was fluvoxamine. I don't know if you have any opinion on that. There was also, and Dr. Mallad, if you've done anything on that, because it's just brand new. I didn't even have a chance to look at mechanism of action of how they feel like that might be a benefit. Before we leave the vitamins though, there was someone that just popped up on vitamin C, and I think Dr. Seheult, you had that on your protocol, do you not? Zinc, vitamin C, and vitamin D, is that correct?
Yeah, I just don't know what the correct dose is for vitamin C. Some people say 2 grams a day, 3 grams a day. Some people say, you know, half a gram. I think you probably should take thiamine if you're going to take mega doses of vitamin C, because it helps modulate, you know, the stones and things of that nature. The only thing I would mention for those that are treating in the hospital is using mega doses of IV vitamin C can sometimes cause problems with glucose testing. May also happen outpatient as well. High doses of vitamin C can sometimes make blood sugars on point of care glucose testing appear higher than they actually are.
Right. And that's also its renal process. So they definitely need to drink more water. So that's another factor as well. And Dr. Mallad, as far as I know, we're trying to touch mostly on outpatient, but I know there's going to be some inpatient doctors that are going to wonder, because there's such compelling data on vitamin D and zinc in particular. Should we be adding that to the protocols inpatient?
As far as I know, it's been given, like where I'm working in 3 hospitals. Yeah, they do give whenever the patient come in, along with if the patient has severe, they do add, you know, zinc and vitamin C. I mean,
okay, so that's being done then. Okay, yeah. You say the same, Dr. Seheult. Okay, you know, we're going to have a lot of questions. I see up in the chat, you know, it's just like there's amino acids, there's another medication, there's another medication. I anticipate we're going to need to do another one of these talks in a few weeks, because we're going to have to probably boil down these meds. And as we kind of learn more about them, utilize your expertise, my clinical experience, to see what maybe makes sense in some of these cases, because we won't have the time to wait around for studies. And if it is something that's potentially safe, or maybe they're already on an antidepressant, and we're seeing that these patients that are maybe getting, you know, venlafaxine are actually not having significant symptoms at all. I mean, so there's clinical aspects we can put into that, but I think we'll have to obviously defer that to the next talk. And I think that the next one we'll probably have to get into also the vaccine situation, because we've got a huge problem with that, with people that are opting out of the vaccines, and it's a whole nother subject, but I don't know that we'll have time to get into that tonight. I've been trying to, and I think you were as well, Dr. Seheult, trying to answer some of the questions that were in the chat. So if we didn't get to your question, please, you know, submit it so that we can add it to our talk, because they're all important questions and we won't just have time to cover each one. But as far as, you know, our main points, I think that we're, you know, we've got till 7:15, so we have 10 minutes to wrap this up, really, to keep on schedule. And so there's some stuff on post-COVID complications, because at this point, I've seen enough patients that were sick earlier in the year last year that are having some chronic symptomatology. And you as a pulmonologist, Dr. Seheult, and then you as infectious disease, Dr. Mallad, you may actually be experiencing some of these as well. And I know you had maybe a slide on that. So I'll start with you, Dr. Mallad, on post-COVID.
Sure. Just one point I want to add with all the medication you guys are prescribing. So I saw, it's funny when I read it, but there was a meta-analysis for use of honey for, you know, early symptoms of cough. And they found that this antitussive, like honey was better than antitussive medications for initial,
Good enough for the Egyptians, it's good enough for us. And so
I know, right? Okay, let me share my screen. Okay.
And what we're talking about, just while you're getting that slide up, is going to be the post-COVID complications, because I know I've seen many patients, in fact, you know, respiratory effect of shortness of breath, almost like an asthma condition when you never had it before. And Dr. Seheult can talk about that, I'm sure. But neurologic, cardiac, autoimmune, dermatologic, rheumatologic. I've had a lot of patients that have developed polymyalgia that's lasted now for 6+ months. And there's been some cases where I've actually given them hydroxychloroquine in that case as a test because of its effectiveness with rheumatoid arthritis, just in particular, and it actually did have some relieving action for them. So that was interesting too, but I'll let you go ahead, Dr. Mallad.
So most of this is slides collected from British Medical Journal guidelines, because I thought they had very methodological, view or approach for this. So basically, it's still there is no agreed definition, but anything lasts beyond 3 weeks from onset, you can consider as, long COVID or post-COVID symptoms. The most common symptoms which last are fatigue, sleep issues, and muscle weakness. Okay, and these can last up to like 12 weeks. Positive test of COVID is not a prerequisite, because many people don't even, come to office to get tested if they are having mild symptoms or maybe asymptomatic. So recent study showed only 65% people had returned to their previous health within 14 to 21 days after positive test. Why? Maybe persistent viremia due to weak immune response, or probably relapse, or inflammatory reaction, deconditioning, or post-traumatic stress may all contribute. As Dr. Hansen mentioned, the symptoms are very wide, but I'll try to go through each and just give a little bit what can be done. The symptoms like cough, fatigue, low-grade fever may relapse and remit. There might be shortness of breath, chest pain, headache, and neurocognitive difficulties. There might be muscle pain, weakness, GI upset, even metabolic disruptions, like poor control of diabetes can be seen in post-COVID phase. Then variety of rashes. It can be anything. There is no defined rash. Vesicular, maculopapular, urticarial, chilblain, like they also called it COVID toe. You can also see like thromboembolic conditions. You can see depression, mental health conditions. And also, as I already said, that there could be skin rashes, and they recommend that no need to refer or investigate these if patients are otherwise well. This is a representation. So what do you do? So if the patient presents after 3 weeks with these symptoms, again, clinical assessment, full history, assess the symptoms, check their temperature, heart rate, rhythm, blood pressure, respiratory exam, functional status, pulse ox, and clinical testing. And these are the lab tests. Depending on your clinical judgment, you can use like blood count, electrolytes, liver and renal function, troponin, CRP, creatinine kinase, D-dimer, BNP, and even ferritin level. And other investigations like chest X-ray, like for example, if you want to assess for like post-COVID secondary infection, urine test, and EKG. Coming to management, assess and manage comorbidities. Like they can come up with like worsening diabetes, like difficulty controlling sugar, so you have to manage accordingly, or kidney problem, or neurologic, or cardiovascular, so each system-wise. And they also recommend pulse ox monitoring even in post-COVID phase. Symptomatic care. So any cough more than 8 weeks, you have to be looking for, like super infections or other complications such as painful pleural inflammation. And when you are working up for super infection, I would recommend getting a chest X-ray and to see if there is any consolidation before like giving antibiotics. And as Dr. Schultz mentioned, like any productive cough, typical like pneumonia. And then they mentioned that, like a breathing control exercise can help in decreasing the irritation of diaphragm. So basically it was breathe slowly in and out with inspiration to expiration ratio was 1:2 for 5 to 10 minutes and few times a day. And they noticed that this helped in prolonged cough symptoms. Also if you suspect reflex, give proton pump inhibitors. If they come with chest pain,
Oh, I'm
Sorry?
sorry. Just for the sake of time, we'll probably want to get through them a little quickly because the main thing that we really want to gather from this is that for the clinicians, you've got to be sure that you're looking for multi-systemic manifestations post-COVID. So if you
Yes.
start seeing neuropathy, you start seeing, you know, obviously persistent cough we would expect, but there's going to be other things out there. And you can even maybe scroll through your slides. You can see, I mean, there's cardiac manifestations. There's, you know, the things that, you know, potentially they could lead to congestive heart failure because of the myocarditis that can occur, you know, so there's lots of different manifestations. And the point really that I think, and not to interrupt you there, Dr. Mallad, but just for the sake of time, is going to be to make sure that as clinicians, we are looking at patients clinically in the big picture and not just thinking of this as a respiratory illness. And with that, I should give Dr. Seheult a chance because I know we've got a few more questions that we should probably hit on just so that we make sure we covered everybody to the best of our ability. You're muted, Dr. Seheult.
All right, so just real quick, I just wanted to share my screen real quick, and we'll move through this real fast here. Is one other thing that I just thought about when Dr. Mallad mentioned honey is Eucalyptus Essential Oil. There is some data that it can be used. You can see here, eucalyptus oil basically turn these immune cells into very fast eating machines here, just like LPS would normally do. The other thing I wanted to mention was picking up what Dr. Hansen said about exercise and myocarditis. It's really important. And actually, I saw it on Dr. Mallad's slide there, that if somebody has chest pain or you're at all concerned post-infection that they have myocarditis, they really should not be exercising. The American College of Cardiology has put out a recommendation at least 10 days after they have symptoms, no exercise whatsoever. I noticed on Dr. Mallad's slide there that, you know, for athletes that have pericarditis, it's up to 6 months. I thought that was very good information. But one of the things I wanted to talk about in terms of this is that thing about exercise. And I found this study to be very important, especially now with a lot of our patients who have depression and anxiety as part of these long haulers or even those that have not been infected. And this was a study that was done up in Ontario at McMaster University, where they took students that were in university for 6 weeks. They were under a lot of stress coming up to their exams, and they randomized them to no exercise, moderate exercise, or high intensity exercise. And what they noticed was in those people that did not do any exercise in gray, they very quickly within 6 weeks time went up fairly high on their depression scale. So we've been into this pandemic for about a year. Depression and anxiety is abundant and rampant, not only in the adult population, but also in the pediatric population. There was just a study that came out showing this. Look what exercise, moderate exercise. That means getting your heart rate up to about 150, 140, 3 times a week for about 20 to 30 minutes. So not anything big, but you can see here that it completely eliminated in these students depression. It completely eliminated anxiety in this blue group and perceived stress. Now, notice that those that did high intensity exercise didn't seem to work so much. So you don't need to be an Olympian to get this effect. In fact, you don't want to be an Olympian. The one thing I'd also show you here that sort of goes along with this is look what it did to inflammatory markers like tumor necrosis factor alpha and IL-6, both of which are implicated in the severe causes of COVID-19 when they come to the hospital. Exercise 3 times a week was associated with a large drop in tumor necrosis factor alpha, something that you'd want to have if your body is undergoing a viral infection. So I bring that up because something as simple as daily exercise, getting out into the fresh air, getting sunshine can have a tremendous impact, not only on your physical health and your immunity, but also your mental health.
Excellent. Well, thank you so much, Dr. Seheult. I wanted to go ahead and go over some of these other questions because I tried to pick and choose, but there were some that we maybe didn't quite touch on. Many of the questions were actually about the vaccine. So like I said, we're going to punt that to the next talk because that's a whole nother subject altogether. The one question is just, you know, how we are supposed to identify when to send a patient to the hospital. And I know in my clinical experience, you know, pulse oximetry is helpful because of course, when you call 911 because you're in respiratory distress, They judge a lot by where you're standing. And so that can be a useful tool, that if you're under 89, for instance, and in distress, it's going to have multiple factors. How old are you? Do you have other comorbidities? Those kinds of things. But I think pulse oximetry, although good luck getting one, is probably helpful for our patients. If we have especially a high-risk patient, we may advise them to go ahead and try and get a pulse oximeter. The other thing is going to be, though, go ahead, Dr. Seheult, you had a question?
I was going to say, those who have a Samsung phone, some of them actually have pulse oximeters built into it. There's also, this is a shameful a plug for a Milligram video that we just did a few weeks ago that actually goes through this very specific question about pulse oximetry, where you can get one, which ones are good, bamlanivimab if you need it. So if any provider out there gets asked this, you can simply just send the video. It's on the Milligram YouTube site, 10 tips if you have COVID-19. It's gotten over 1 million views, and it's got all that information in there.
Right. And so that's definitely helpful. I think that's going to really be the thing, because especially if hopefully we won't get to the point where LA County is where their EMS providers are being told they have to basically do battlefield triage and not take everyone to the hospital and decide who lives and dies. And so that's just the most horrible situation that our healthcare system could be in. And unfortunately, LA is dealing with that right now. Hopefully with tonight's information, there can be more interaction from physicians at an earlier phase. We can mitigate, hopefully, this hospitalization surge that we're having to deal with, because the thing we don't know about is the anticipated future surges with the mutated version of SARS-CoV-2. So, we've got to be prepared, because even though the vaccine rollout is occurring, we still have a delay before we get enough individuals vaccinated. We will continue to have patients calling daily, just like I did today, at least 10 to 15 patients with new COVID symptoms. We'll have patients that can't get the vaccine because they've had allergic reactions in the past to other vaccines and they're not a candidate. Or we'll have what we see now, especially in the healthcare worker arena, where we have potentially up to 40% of healthcare workers denying or declining, I should say, to get the vaccine. Maybe they'll do it later, maybe they won't. So we're going to continue to see cases. So we need, as clinicians, to be prepared to do what we can to educate those individuals. And there's simple things that can be done that are, fairly innocuous. And that's going to be those things we talked about earlier on. It may get a little bit more murky as you talk about the individual medications and if they have utility or not. If we go only off of the studies, I think we may be lacking and maybe not quite doing as much for our patients as we could, just from my clinical experience, because I do see responses and it's not just coincidence. It's there. So I think with time, we're going to see some medications that'll probably fall off the list and others that'll come to the forefront. And I know there's a lot of medications that everyone is throwing in the chat. So we're taking that down. We're going to look those all over. We'll try to address those in the next session. Maybe we'll kind of start with that at first, although that'll probably end up being a full talk in its own. But we do need to kind of get into the vaccine thing. And we should probably do it sooner rather than later, just because of the feeling, I think, out there about not understanding how the vaccine works, potentially, all the false information that potentially the public is getting on that. That does it integrate into your DNA? Are there microbots in it? I mean, all these different things you've heard about, right? And so it's no wonder people are just really scared. So I have to spend a lot of time just educating patients on what I understand about the mechanism of action on these vaccines, and if they are a candidate or not, based on their predisposing, condition maybe of a previous reaction. But other than that, hopefully we'll have a little more information on that as well. But there was maybe a couple questions that we didn't quite cover. And it's vaccine. There was one about, and I thought it was very interesting, about our immunity after COVID. So that's a big question. And I know clinically I've seen patients that had COVID 6 months ago, and they've got it a second time. They had a negative test in between. They were asymptomatic, and now they're significantly symptomatic in the second go-round of this virus. Now, in my assumption, because, and both of you maybe can give us your opinion on this, because I think it's really important for us to understand as clinicians, I assume that because this is in the coronavirus family, very similar to our rhinoviruses and others, and that our humoral immunity, we're probably looking at about 90 plus days, and then you could potentially, have that virus family not have lasting immunity, and you can get sick again. I'm seeing that potentially around 4 months later, that these patients are becoming susceptible again after having a natural occurrence of this virus. And maybe I'll talk to first, well, who will I pick? Oh, here, I'll go with Dr. Mallad first, and you can maybe give us your opinion on that, because I assume that we're talking about, those patients that got it, they probably will need to look to get vaccinated probably at about 3 months is my assumption, just based on clinical experience.
So the data came by the 90 days because case reports, they saw that, the reinfection was seen after 90 days. And the immunity, that's not like a standard number. For example, some patients who have very severe infection, they will have very high antibody titer, and that can last longer. Versus some people who have had milder infection that might last, a shorter time. But what they saw was after 90 days, they were seeing reinfections. So that's why this is where the number came from, 3 months.
Right, so that falls right into clinical experience. And so, Dr. Seheult, do you have the same experience in your practice? Oh, you're muted again.
Yeah, so I have seen a few patients that have had some reinfections. That has been the minority. What we just interviewed actually Shane Crotty, who's the immunologist down at La Jolla Institute, very well-renowned. Actually, Fauci held up his research at the recent Senate hearing. He's just published in Science an article that I just put in the chat, which you can read. It's titled "Immunological Memory to SARS-CoV-2 Assessed for Up to 8 Months After Infection." And the data looks pretty good, actually. They say spike-specific memory B cells were more abundant at 6 months than at 1 month post-symptom onset. CD4 T cells and CD8 T cells declined with a half-life of about 3 to 5 months. But again, these are surrogates for true immunity. We don't know if they're just sort of hovering in the background and they're decreasing the number. But obviously, more research and more studies are going to come out as time goes on.
Thank you very much. And I think that, with that, I think we're over time, so we probably better wrap this up. But thank you very much to both of you for coming on this talk, and also to everyone that tuned in, and especially to the San Bernardino County Medical Society for putting this on. And we'll definitely get this information out. I think they were talking about it in the chat, how they're going to get the slides and any of the information on dosing of meds and things. And again, just as a disclaimer, we're in no way proponents of specific dosing of anything necessarily. This is going to be your clinical judgment, but we want to make sure that you feel comfortable doing more, because there is data to suggest that we definitely need to do more, and that there are things that we can do that can make a huge difference in keeping these patients out of the hospital. So with that, thank you to both of you, and thank you to everyone else for tuning in tonight. And we'll see you guys again, I imagine, real soon, because we got way more questions than we can even get to.
Thank you.
Thank you.
Thank you, everyone. We'll talk
Thank you.
soon. Thanks so much.